Hi guys, welcome back to my YouTube channel. So for today's video, I wanted to discuss how I present patients during rounds. So if this is something you're interested in, please keep watching. Also, please don't forget to like the video if you liked it, as well as subscribe for more content like this. Now let's get into it. Okay, so the first thing I want to share is that presenting patients during my internal medicine rotation versus now while I'm in my surgery rotation is completely different. So for my internal medicine rotation, the attendings I was with, they wanted a very thorough physical exam and they wanted you to present in a very formal fashion. Versus surgery, which is the rotation I'm in now, it is very relaxed. And I remember the first time I presented a patient during my surgery rotation, I presented the patient like I did in my internal medicine rotation, so it was very thorough. And at the end of the patient presentation, the senior resident was telling me that my presentation was very thorough and detailed, but from now on, she just wanted me to cover the pertinent information. So that's something I want to point out. Not every attending or senior resident you're with wants you to do a full formal patient presentation. Depending on what attending you're with and what senior resident you're with, they're going to tell you exactly what they want and you want to follow what they want. So for me, it was a little hard for me to go from being very detailed patient presentation to only a little bit of information that was pertinent for that patient. That's something to be aware about. And the other thing I want to point out is that your patient presentation will also be different if you're doing a follow-up on a patient you've already seen before. For example, if they've been in the hospital for a couple of days and you've been following them those days, your patient presentation will be shorter and not as much detailed. You're just going to let the attending and residents know what is different or improved in your patient overnight compared to when they first came in. And the other situation is, for example, if you're seeing a new patient, you have to get a full history and physical on them. So you have to get a full HPI, you have to get a full past medical history. For example, their surgical histories, you have to get their family history, if there are any significant diseases in their family, their social history, if they drink or smoke, if they exercise regularly, what their eating habits are like. And then also you want to add if they have any chronic illnesses such as high blood pressure or diabetes. So the past medical history portion is very important because it gives us an idea into the person's health and why they may be coming into the hospital now. Okay, so after HPI and past medical history, then you go into the vitals. So the blood pressure of the patient, the heart rate, the respiratory rate, the temperature, and the oxygen saturation for that patient. Now I'm going to give an example of a normal physical exam, but I'll also point out here and there after I give the normal what you would probably hear or see, for example, heart failure patient. So for a physical exam portion in my internal medicine, it was very much more detailed compared to my surgery rotation, which I'm in now. So for example, for internal medicine, we had to list everything that we did. So, and I would always go from head to toe. So first thing, always general inspection. You look and see how the patient is the day you visit them. If they're in any acute distress, that's the first thing you say. And you can also say if you see them sitting in a chair, for example, or if they're laying comfortably in bed. So for general inspection, I would always say something around, okay, 67-year-old female in no acute distress, laying comfortably in bed. Moving on to HENT, head, eyes, ears, nose, throat. Normocephalic atraumatic, pupils equal round reacted to light, extraocular movements intact, anecteric sclera, no conjunctival pallor, and oral mucosa moist. Moving on to the neck. Neck is supple. Trachea midline, no JVD, no carotid bruits. For the lung exam. Lungs are clear to auscultation bilaterally, non-labored breathing, no wheezes, rails, or rhonchi. Heart exam. Regular rate and rhythm, S1, S2 auscultated, no murmurs, rubs, or gallops. The abdominal exam. Abdomen is soft, non-distended, bowel sounds heard in all four quadrants, non-tender to both light palpation and deep palpation, no guarding, no rebound tenderness, no hepatosplenomegaly. For GU exam, no suprapubic tenderness, no CVA tenderness, and you can also say if the patient has a Foley or not. For the lymph exam, I always check for cervical and supraclavicular lymph nodes. So you can say no cervical or supraclavicular lymphadenopathy. And then for extremities, you check for edema or cyanosis. So no edema, no cyanosis, no clubbing. Radial and posterior tibial pulses 3+ bilaterally. And you can also check for capillary refill. So our normal capillary refill is less than 2 seconds. For MSK exam, proximal and distal muscle strength 5 out of 5 in all extremities. Normal bulk and tone without atrophy. For neuro exam, ANO ×4, cranial nerves 2 to 12 intact, intact sensation to light touch, vibration and pinprick. Deep tendon reflexes are 2 out of 4 and symmetric bilaterally, and downgoing Babinski bilaterally. For psych, you can say the patient is pleasant and cooperative and appropriate mood and affect. Now, for example, if the patient has lobar pneumonia, you want to also check for those special lung sounds such as egophony, bronchophony, and whisper petrilici. Another example is if the patient came in for heart failure. You want to check for edema in the extremities and note if it's pitting or non-pitting edema, as well as if you hear crackles in the lungs. So that was the physical exam portion. Now moving on to labs. So you also want to check for the patient's labs. For internal medicine, I had to include all the labs, but for surgery, I only let the resident know about the pertinent labs. For example, if the potassium is low or high, or if the creatinine is low or high. And then moving on from labs, we go to imaging. So if the patient had a CT abdomen or a chest x-ray, you have to discuss in your presentation what the findings were and what it's significant for. And then after that, you end with your assessment and plan. And the assessment and plan was the hardest part for me when I first started doing presentations and writing my notes. But with practice, you do get better at it. And the first thing you say on your assessment plan should be the most important thing. For example, if they come in for heart failure should be your first thing on your assessment plan. Now, I want to point out some attendings want you to put first on your assessment and plan if the patient requires supplemental oxygen, such as if a heart failure patient is on, for example, 3 liters nasal cannula. That should be your first thing, acute hypoxic respiratory failure on 3 liters nasal cannula. Then the second thing is heart failure. If the patient comes in, for example, in an exacerbation of their heart failure, for the second point in your assessment and plan, acute on chronic heart failure. And then you list according to the next serious thing. So let's say, for example, the patient has a low potassium. So you can say hypokalemia, and then you give your reasoning why you think it may be low. It may be low due to a diuretic they're taking. That's just an example. So again, for assessment and plan, it gets better as you keep practicing it. So that was the patient presentation for a new patient. Now, a patient that you've already been seeing for a couple days and you're just following up with them every day, that presentation is less. So the thing that you would not discuss for a patient that you're following up with is their past medical history. And your HPI for them would be a little shorter. You would cover more of if there were any acute events overnight. For example, if the patient required a nasal cannula for their oxygen saturation. And then you would discuss how the patient is feeling the morning you went to go see them. And then, of course, moving on with vitals, physical exam, and your assessment and plan. So the main difference between a new patient presentation versus a presentation for a patient you're following up with is you leave out the past medical history and your HPI is a little bit shorter. Now, my patient presentations for when I'm in my surgery rotation now, they're a lot more quicker and to the point. So for example, if they had a laparoscopic procedure, I would make sure I covered the abdomen or GI exam, and I would also point out if the incisions are clear, dry, and intact. But I would not focus, for example, on the heart exam or the lung exam. So that's the main way I've noticed internal medicine patient presentations being different from surgery patient presentations. And the other thing to note is that when you're in internal medicine, your rounding can take up to like 3-4 hours versus surgery. Rounding is super quick. You get it done within an hour or less. So that alone will tell you how much more detailed presentations are in internal medicine versus surgery. So this is my quick little video on patient presentations during rounding and how I found patient presentations in internal medicine versus surgery rotation. Let me know in the comments below what you have experienced during your internal medicine and surgery rotations. Thank you all for watching, and I'll see you in my next one.